So our first speaker tonight is Dr. Hazel Keedle. We're very lucky to have her with us tonight. She's a senior lecturer in midwifery and director of academic midwifery programs at Western Sydney University. She authored Birth After Caesarean, Your Journey to a Better Birth for consumers, and more recently, the Clinician's Guide to Better Birth After Caesarean. And also, Hazel leads the large Australian birth experience study, the BEST study, and its international collaboration, which has been incredibly useful and helpful. So, welcome, Hazel.
Well, thank you very much for having me here tonight. I'm going to share a presentation with you. Let me just share my screen and just confirm that everyone can see that. Yep, excellent. All right, well, thank you for having me here tonight. And I'm very happy to talk about the birth trauma inquiry and how we can advance midwifery practice in Australia based on the findings from the birth trauma inquiry. This is going to talk about some quite strong topics. I think that was a giveaway with the title anyway, but just to let you know to take care of yourself. And there might be some more difficult things that we talk about, important things, but they might be difficult. So just maybe do some nice self-care after this session. Okay. I'd also like to give an acknowledgement of country. I pay my respects to the Darug people, the traditional custodians of Parramatta where I work, and the traditional custodians of the Blue Mountains where I live, which include the Darug and the Gurra Wiradjuri and Darkinjung peoples. So the birth trauma inquiry didn't just come out of thin air. There was a lot of things that led to it, and not everyone really understands the lead up to the birth trauma inquiry. So I thought I would just touch base on that. There were these several links in the change, and it wouldn't have, I don't think, occurred if just one of them happened. I think they just happened to, it needed to have all those different links. Most definitely, there was consumer activism, and that was from different consumer groups, including a big group complaint that happened down in Wagga in New South Wales, and other complaints that were coming through. And so consumer activism groups were really getting involved and trying to have the conversation. There was always people trying to reach out to politicians, and there wasn't always getting much of a reaction, but there was one politician who was particularly interested and did respond. And I actually remember being CC'd in these emails to all these politicians with a consumer group. And it was really exciting when Emma Hurst actually responded and said, "Oh, please tell me more about this birth trauma thing." So that then meant that we could have a conversation, and we had our obstetric violence research paper coming out in the months after that conversation, actually. And so I was able, but it had been accepted already. So I was able to talk to Emma about what obstetric violence was and what our paper had found from the birth experience study. And that facilitated some meetings. You can see a meeting here with Emma, her wonderful aide, Tess, Hannah, myself, and Bashi from Human Rights and Childbirth. And that was a really exciting meeting when we sat down. And I don't think even then there was the thought that a birth trauma inquiry could even happen. And again, we had these meetings, but that was a little bit far off because other things hadn't happened to that point. Like I said, there was consumer activism, and then there was this big group inquiry, this group complaint that happened from a bunch of women in Wagga Wagga, and that was building momentum as well. And Emma was getting to hear about that. And then there was a big political change. So we had a change in government in New South Wales. And for the first time for a long time, the Labor government got in. And I think that was also, well, I know it was a really important part in that chain that we went to a more progressive government. And then that government being more interested to listen to what was happening. So there was a night in, I think it was June, a couple of years ago now, where I got a phone call from the lovely Tess in the image to say, "Guess what, Hazel? We've got an inquiry. We've got an inquiry into birth trauma." And that was really, really exciting. And then it was exciting to see how the terms of reference were developed and reviewing them as well and going, okay, well, they're quite comprehensive, so that's really exciting. But it wasn't just one thing. I can't take the credit for it with the obstetric violence paper at all. There was lots of different things that happened, and our paper contributed to it. But there was lots of other work going on in the background. And then it was the right environment too. So just wanted to give a nod to that. So with the New South Wales inquiry into birth trauma, when it opened, it was really, really exciting, but in a strange way, because we're kind of going online on social media and saying, please share your story, but knowing that that doesn't mean that that was going to be a very pleasant thing for someone to do. And so personally myself, I found myself at a crossroads at times to go, well, I want to push this out there, but we also need to do this in a supportive way. And that's tricky when you're just doing a video on social media saying, please share your story. So it was difficult to, really go out there, but we also needed to. We could see, it felt like this was going to be a really pivotal time and a pivotal point in maternity care in Australia, not just New South Wales. So there was a lot of action on social media. And I think that action from a variety of different consumer groups and speakers really worked. There were over 4,500 submissions, and not all of them are available online, but a good majority are available online. From that, there were 6 hearings, and those hearings were in Sydney, in Wollongong, down at Wagga, which was highly appropriate since that complaint had come out, and then back in Sydney again. And the select committee were very aware to listen to a broad range of voices, and that was from the clinicians, but also from women. And if you tuned into any of them or you saw snippets on the news, they were really quite emotive. And from the very beginning, they wanted it to be a trauma-informed inquiry. Now, Emma, as the chair, she's actually from a psychologist background, so I think she really got that. And I was invited along with a couple of other people to meet with them even before the hearings to talk about what the issues are to this select committee that may have never even heard of it before. And there was a variety of different politicians from different walks of life in that committee, but also to have it was a really good conversation. I hope I never forget what it was like, but to sit down with myself and other people and First Nations representatives, and then this group to go, okay, how can we make it trauma informed? And there were certain things that happened during the hearings that you wouldn't have known, but they were removed, like a big bright light on the woman, for example. So I think they did do that in a good way. There's always room for improvement, but I think that was done pretty well. And then there were 43 recommendations from the select committee to try and reduce preventable birth trauma. We know it was recognised you can never reduce all trauma, but to try and reduce preventable birth trauma. So I'm going to focus on 5 areas where I think as a midwife myself and as a midwifery researcher and author that we can really focus on and lead the change. I'm sure we've got plenty of midwives, but if you're not a midwife in the audience, then this certainly does still relate to you and how you can then support this large profession of midwifery to do the change. And also think about how does this impact you in your profession as well. So the first recommendation was about birth plans. But these are the ones I'm going to focus on, not the first one in the list, but the ones I'm going to focus on. It actually was recommendation number 18. And the recommendation was that the New South Wales government make evidence-based birth plans freely available as a guide. And then, so what I've done is I've got the recommendation, then I've got the response that came out from the New South Wales Health Minister. Sorry, I'm just trying to move my little thing at the bottom. There we go. And the response was that the plan should consider and explore the woman's broader health needs, her preferences, her choices and decisions. This plan should be respected, communicated and documented, which is good. But I always wonder, what do women actually say about birth plans? So the data I'm going to present to you is from the Birth Experience Study. Just to give you a recap, that was live in 2021. We got nearly 9,000 completed responses, and we had covered almost everything in that survey from pregnancy all the way through to the postnatal period, and respect and interactions and everything involved. And women were very generous with their stories. And we did ask questions about birth plans. So let's have a quick look at that. Now, this data, so please don't share this data at the moment because we're just writing up this paper. And I do believe, I think I even saw the person I'm working with on this paper in the audience today. So looking at birth plans, well, the women that did our survey found that 77% of the women actually created a birth plan. So we found that they had got one there, but 56% found support for that, which means the other half did not find support, which is a little bit disappointing. So here's some comments with this. This woman said, I was not encouraged to write one and felt too intimidated to present mine to the attending midwife in the hospital when I arrived in labour. Personally, I often think that there are a lot of birth plans that never make it out of the bag. You know, women have sat and thought about it and maybe come up with one, but as soon as they walk in the room and they're bustled around to do all these things and no one's actually said to them, you know, what's in your bag? Do you have a birth plan? Shall we chat about that? And that moment is then lost if we don't connect that straight away. This woman says that the narrative around birth plans when she was pregnant was that they were deemed as something that only naive mums would do. I heard a lot that the only plan you should have is to set no plan because you can't control anything. Unfortunately, this meant we were very reliant on our midwife and didn't research all the intervention methods, etc. And we were very unprepared when an emergency C-section was required. So that kind of belief that you should just, you know, not plan for anything, give that up, that actual loss of control also can contribute to women feeling that they had a traumatic birth. So as a very quick overall, and there is going to be a very exciting paper that we're working on at the moment that goes much more into depth on both the quantitative questions we asked, but then all the comments that we got. I think we got over 2,000 on this. And so a very big overview from that was we found that birth plans were beneficial when they were initiated by a midwife. So if in that antenatal period, they were able to initiate a birth plan, talk about a birth plan and bring it up. And then also, obviously during labour, recognize and acknowledge the birth plan and encourage the use of it. That obviously in a continuity care relationship is much easier to do than fragmented, but it can still be done in the fragmented model. That women were very aware that they need to be flexible. You know, there's often this belief that, you know, women are making very strict, rigid birth plans and therefore maybe they have too high expectations. But actually, what we found from women's comments is they're pretty smart and they can figure out that birth doesn't always go one way. There can be lots of things that can happen, and that they create these flexible birth plans in lieu of that. I think we often are exaggerating how many women have got very, very strict ones and then just making that as an excuse why clinicians don't like them. Majority of women made flexible ones. Birth plans were beneficial when they were trauma informed as well. And this is particularly important for women that have experienced trauma, previous trauma, whether that be birth trauma or other trauma, and then coming into our maternity care system. So what would a trauma informed birth plan look like? And really that is asking women, what is safe for you? What does safe look like for you in collaboration and integration within the system? And that they're supported, right? What is the point of making a birth plan if no one's then going to support it? And obviously we found that that was the realistic experience of many of the women in our study who did develop one. And that just seems crazy. I mean, it might seem that they're far reach, but most of them are not. Most of them are flexible and very much grounded in what's happening in maternity care. All right, let me move on to the other one. And that's the big one, I think, is continuity of care. Now, the recommendation from Recommendation 9 was that the New South Wales government ensure that all women have access to continuity of care models with a known provider. And the response is that they're committed to increasing access to maternity continuity of care and carer models. And they have been working on this, absolutely. And there has been in the budget money towards more MGP models across New South Wales. However, we do just keep hearing that women say there's just not enough spaces. You know, they try and get in, and if they don't get in straight away, then they're not offered, then they're not able to access a space. And we've really got to think about how we get our midwives rotated into continuity of care programs and feel supported and feel nourished and then flexible enough to be able to have some time out if they need to, and then able to come back in. It shouldn't be an all or nothing. You're either doing this forever or only full time or you can't do it. Like we have a very flexible work group of women, right, as midwives, majority of women who need flexible work because we're often the carers, we're often mothers and parents and also carers for elder generation, as well as may well be having, you know, chronic illnesses and issues for themselves, that so many will need a part-time caseload or job. So we need to have that flexibility as well. That could include job sharing, all that can fit in a continuity of care model, in fact, extremely well because of the flexibility within the model. So we need to have that as well to support our midwives so they're not getting burnt out and they can have more options. So this is what they suggested. Now we know from our birth experience study that the maternity model of care actually has a really big impact, even on birth trauma and mistreatment and obstetric violence. So these are three things that we asked women in the survey. Now, mistreatment was using a mistreatment scale called MIST, which is developed in Canada, where there's 7 statements of types of mistreatment, which are based on the Boren's 7 typologies of birth trauma. And then if they said yes to any of them, then they had experienced birth trauma. And we found that scale really quite interesting because the mistreatment average in our population was something like 35%. However, if we said, did you have a traumatic birth, that was sitting at 28%. And if we said, if we asked, did you experience obstetric violence, that was sitting at 11% across the whole cohort of women that we surveyed. So this mistreatment score is quite interesting because it actually picks up more than directly asking about birth trauma or obstetric violence, something we need to explore a little bit more. Now, on this graph, which looks a little complicated, but it's really not too bad, not too complicated, what it's showing you is the different models of care. So we've got standard fragmented care, and then GP shared care, private obstetric care, midwifery group practice in a public hospital, and PPM is privately practicing midwives. And what you can see is if you think about our numbers across, so 28 would be our standard for birth trauma, 35 for mistreatment, and 11% for obstetric violence. The ones that reduce them are these continuity of care models. In fact, they're the reduced the most in the privately practicing midwife group. So I think it really shows that continuity of care makes a difference. And if you want more of a difference, you need to be really focusing on that independent, privately practicing midwifery care, having the lowest across all of those 3 areas. So continuity of care with a midwife, what does it show us? It shows us that it decreases the cesareans. And our cesarean rate, yet again, has increased. We're now over 40% across Australia from the 2023 data that's just been released in by AIHW. It decreases instrumental births. It's cost effective, which government person would not like that. And it increases positive birth experience. And I'm going to overlay that with, actually, it also reduces trauma and reduces obstetric violence. And so if we're looking at what can be preventable, what can prevent birth trauma, then a model of care really makes a very big difference. So what does this one say? I've got my things in the way. This says postnatal debriefing. That's right. So, sorry, just go back one. The recommendation was that the New South Wales government establish formal debriefing clinics attached to all public hospitals with maternity services. And the response was they're committed to ensuring that women are connected to the care and support they need. This includes providing a postnatal debrief if the woman chooses, maybe from the health practitioner connected to or independent from the maternity service that provided the care. Debriefing is something I've got a little bit of interest in now since the birth experience study, because we actually asked questions about this and we've now published a paper on it. And it's interesting because the evidence is on the fence about this. However, it was more research needed, really, is what was needed. So we asked women what their experiences of debriefing. We found that 53% spoke to a clinician after birth. So knowing that is, every woman experiences this, that's not actually what every woman was experiencing in Australia. And 60%, if they didn't, so the 47 that didn't, from that, 60% would have liked to, they would have liked to have had the opportunity, but the opportunity was never there for them to have. We've looked at this, and I did this actually with a medical student. It's my way of trying to look at collaboration for the future with our medical students. And this medical student, she was amazing. She did a research project with me, and her project was to analyse all of the comments that women said about debriefing. And we found that there was helpful debriefing and unhelpful debriefing. Now, I've given a link to the paper in a minute, which has got a lot more information, but just quickly, we found that with helpful debriefing, there was the importance, first of all. So women really found it as an important process. You can see here, she says, giving birth is a massive rite of passage for women, and we need to debrief and discuss it with trusted people in order to integrate the experience into our lives. So that's whether it's positive or negative, right? So we shouldn't be the ones policing it and saying, well, I think you had a negative one, so you should get debriefing. This is actually for all women, and the benefit was for all women, positive or negative experience. And then the impact that this has. So this woman said, talking about it made me feel like my feelings were validated, whilst not being able to change what had occurred, allowing me to accept it and plan for a positive birth in my future. So it has an impact more than just talking about what just happened, but helping them actually plan for the future as well, which is so important. Unhelpful debriefing, there was that as well. One was, the perception that there was a lack of care. So this woman said, I felt like no one cared. I've been through this hellish experience and everyone just expected me to be a happy new mum. And then there was a defensive response. So having a clinician coming forward to do a debrief and yet actually just being defensive. And I think this is one of my favorite quotes when it's negative, always seems a bit strange, but this is one that a quote that's really been powerful to me, I think, because I feel like it's very visual. She says, I just wanted to know what went wrong. He basically covered himself with excuses. It didn't help. And I kind of see that this person walking in and putting on this cloak of defensiveness, like as a protective shield between them and the woman. And that really was not helpful for that woman. So our research found that debriefing was beneficial actually when it was done by a midwife, because we asked women who they spoke to and who they would like to speak to. And the majority actually wanted to speak to a midwife about this. When there was time given, so more than just walking in, you had a cesarean because of X, Y, Z, write your debrief and walked out. That's not what a debrief is. So giving the time, actually having the opportunity to answer questions, but mainly just to listen. If it was trauma-informed, again, there's that trauma-informed statement. And that's because women have potentially gone through trauma or they've had previous trauma, and a lot of it may have come up during the labour and birth. So the opportunity to talk about that and to try and identify if something was traumatic and how are they now feeling about it and how are they coping with that. And it wasn't a one-off. Women really wanted the opportunity to have multiple opportunities to be able to talk, not just once and then that's it, because that one may not have been the right time. When women talked about the timing, it was so varied as we are as women. And so I don't think there is a perfect time, because we wouldn't be able to get the benefits to everyone. And so I think for that, we need to make sure that everyone along that continuum, even going into the postnatal period and beyond, is aware and able to sit down and have a chat or a debrief. So we did a study on this, and there it is there, content analysis and women's experience of debriefing following childbirth. And if you scan that there, it will take you straight to it, or it should. And that was led by Lucy Bannister, who was a medical student, and now she's a doctor. All right, another one I want to focus on is midwifery leadership. And this recommendation is quite exciting to share. So this recommendation 31 was that the New South Wales government appoint a standalone chief midwifery officer in New South Wales. And actually, I will say I was a bit disappointed by the response, because the response was kind of like, yeah, nah. And the New South Wales Health Chief Nursing Midwifery Officer has a long established robust. Well, I get a bit bored in this sentence, to be honest. But they're basically saying yes, no. However, got a bit of a surprise last week when I got a phone call from Tess saying, something exciting is happening today. And last week, the New South Wales Health Minister did announce the formation of the Chief Midwife role just last week. So thank you to all of those people who have been really lobbying for this and talking about it, because this is actually really exciting. There are many reasons why it's exciting, and let me just share that. Midwifery leadership really needs to be from the top down. We need to have from the bottom up, but also from the top down as well. A chief midwife is needed to drive these changes. If we're seeing as one of the things that's really needs to be driven is midwifery continuity of care, then that can be driven best when you've got a chief midwife there. Also, a chief nurse and midwife will not actually be representative of the majority of our midwives going into the future. When we look at our graduates, we're getting more graduates from the Bachelor of Midwifery program, which means they're not a joint nurse and midwife, they are a midwife. And therefore, if you have these joint positions in the future, then they're not actually going to be representative of our midwives, not our nurse midwives. And that's important. That's also important for the future dreams of our midwives. If they think that, I can only get to that level of leadership if I'm a nurse midwife, then that's really unfair, and that's actually not realistic either. Another reason is midwifery leadership is different. And I've been doing a beautiful research study with an undergraduate student, a midwifery student, who came on as a summer scholarship. And I interviewed a bunch of midwifery leaders, and now we're looking at what did they say? And certainly, I think that midwifery leadership has this very different heart and a very different way of looking at things. And that is grounded in our work of being with women, working alongside with women. And that's very different from the illness paradigm of nursing, of which I also do understand, because I am a nurse as well as a midwife. And it is a very different paradigm. So I'm excited. We have seen the great work that Chief Midwife has done in Queensland, certainly on ratios, on bringing in more midwifery continuity of care and other things that Liz Wilkes has been working on. So it's exciting to see who will be in this role. The role has been formed, and we'll see who gets in there. This was just a word cloud that came up from the interviews that I did to really show, what is it about the midwifery leaders? And you can see right there alongside midwives, the other big word is woman. It's really that partnership that we do. All right, I just really quickly, I'm not sure how I'm going with time, so I might need a little bit of a sign, but I'm going to just go on one more thing. What about obstetric violence? It was mentioned in the terms of reference, and I can put that there with a tick. It was then mentioned in the response, in the recommendations, I'm afraid. However, it just disappeared in the New South Wales government response, like it never existed in the first place, which is disappointing, because if we don't talk about it, we cannot fix it. If we don't recognize it, we cannot deal with it. And yet it will not go away. It won't just magically disappear for women. We know that it's, more than 1 in 10 women experiencing this in Australia. And we've done an analysis, our little research team has done an analysis of all the responses that are up on the New South Wales Birth Trauma Inquiry. And I can absolutely say that the most common theme that comes out is obstetric violence. So for that to disappear, that is a worry, and that is something we need to keep shouting about. It was mentioned more in the chair's dissenting comments from Emma that was in that document, but then disappeared. So I just want to leave that with you. If 1 in 10 women are experiencing it, that means over 31,000 women a year experience obstetric violence. Just by not mentioning it in the recommendations doesn't mean it's going to go away. In fact, it's going to be here, and we can't get rid of it until we start looking at why it's there and what we can do to reduce it. Continuity of care models will help, but we need to really recognise it. All right, I'm going to skip through these ones because this talks about legislation, and obviously we need to focus on that too. So the 5 ways that I think we can move midwifery forward to prevent birth trauma is birth plans, support and facilitate flexible birth plans, expand and sustain midwifery continuity of care models, offer post-birth debriefing, and set up good referral pathways for all women, regardless of the type of birth. Midwifery leadership is needed at every level of healthcare, including a chief midwife, which we will now have in New South Wales, but let's look bigger. Let's look at every state and territory, and let's get it federal too. And obstetric violence, recognise and use the correct terminology to promote healing and action. Whew, that's all of me, and I think I've kind of come to an end. So I can see the nod. Just a couple more things. I've got a book. There's that one, but I've got another one that's just available now. It came out on the 1st of August. I do go into birth trauma and obstetric violence into this book, as well as birth after cesarean. And please do contact me. Stay in touch. You can scan that to go straight to my Instagram. Or if you want to see all the research that we've done in the birth experience study and other research, you can head to hazelkeetle.com. All my stuff is on there as well, and you can contact me through there too. Whew, I think I'm done.
Thanks, Hazel. That was fantastic. And you've got so much to say. And I know, thanks for trying to fit it in, but well done. I've already got half a dozen questions or comments, but, we'll see afterwards. So the next speaker is Louise Thornton. Louise's experience as a registered midwife is over 19 years. She has made a rich has been made rich through attending women both in the hospital system and birthing at home. As a matrescence coach, she supports women to reflect, resolve, and move into motherhood feeling fully consolidated and positive throughout, being able to engage fully with the experience.
Again, honoured to be here. Thank you. Last October, I gathered with 3 other women in the office of the Honourable Dr. Helen Haynes. I'm down in Victoria, and Helen Haynes is the MP for Indi, which is my electorate, and it was a call to action for us about the proposed changes to insurance for home birth, and it leads to this important topic, which is really close to my heart because the birth trauma inquiry and from Hazel's results as well, it's evident that that continuity of care is key, and I've been working with a privately practicing midwife offering home birth. So it was important for us to gather about these proposed changes back in October. So I made that trip and I showed up at that meeting because home birth for me, for women and families and for midwives is important. Many women who I have supported to birth at home as the second midwife choose home birth for the sole reason being they have experienced birth trauma in the system and they want or sometimes need a different experience. They have described their home birth as very healing after such trauma. Thanks to the New South Wales Birth Trauma Inquiry, we have evidence from over 4,000 submissions, not only from New South Wales, but from all states, that this is a national crisis and demands our attention. Throughout my speech, I reflect on finding 5, individualised care, recommendation 9, continuity of care, and recommendations 5, 30 and 41, debriefing. These recommendations from the Select Committee on Birth Trauma can be found on the web, and perhaps the link will be in the notes tonight. So I wish to provide to you my experience from 3 perspectives: that of a daughter, woman and mother, that of a registered midwife or health professional, and lastly, that of a matrescence coach. For those who are not familiar with the term matrescence, it is the becoming of a mother. We have all travelled the transition from child to adult, known as adolescence. Some women become mothers. The emotional, psychological, physical, psychosocial, and spiritual changes can be profound and deserve to be acknowledged, not suppressed. From my perspective as a daughter, a woman, and a mother, my context, and context is everything. I am number 8 and baby of the family. Mum and Dad are now in their 80s. We lived on a farm in the King Valley. I had a free-range childhood and was happy and loved. I qualified as a registered nurse, travelled, became a midwife, married Colin, had 3 home births first and 1 hospital birth for my 4th, trained in the system, worked out of the system, supporting home birth, worked part-time back in the system whilst raising my children. My mother, Elizabeth, I can confidently say loved having babies. As far as physiological birth goes, from my midwifery perspective, she birthed her babies the way she chose to, as she would say, naturally. She never used the language pain, rather a focus. She never had any fear of birth. There was no negativity. I'm grateful for this messaging. It served me well. Despite this, Mum still tells me the same few stories about her experience when she was birthing between 1960 and 1979. Care with the family GP, continuity, yes, not with the midwife. Some examples include don't be a martyr when she declined the gas, and not feeling listened to when she was given her routine enema, hospital policy, and being really scared when she birthed her baby's head in the toilet. This was her. Making choices to rule out the potluck of the care I received and sought continuity with my midwife, 2008, prior to endorsement and MIGA insurance. I held a true sense of my body being perfectly able to birth our baby that I grew in my womb. I birthed exactly the way I chose to with the support of my husband and 2 known midwives at home. When I came to have our 4th child, we had moved location and no longer had access to a privately practicing midwife. We made the choice to birth in the hospital. This is real in regional and rural communities and can be a great disadvantage to women's choice. From the perspective of being a registered midwife, as I evolved as a midwife, I became more sensitive to the effects of working within the maternity system and wiser from experience. I often felt unable or hindered to practice to my full midwifery scope. feeling belittled for allowing a woman more time to labour her way, struggling to trust my midwifery observations when there was little sense of collaboration, feeling less allowed to support women to change positions when the apparent urgency of a vaginal examination required the woman to be vulnerable and powerless, and the frequent undermining of the skill of a midwife when the clock is ticking and the staffing is low and the ward is full, all at the detriment to women and families. I will admit sometimes I lost my voice of advocacy for these women out of fear. In the absence of a continuity of care model, how are we as health professionals afforded the time to get to know women, let alone understand them and their individual needs, or the context of their life, which they bring to that experience? We are fortunate to have in Parliament an expert in continuity of care models, and we have evidence which is consistent and potent. To have received 4,500 submissions where women, partners and carers have come away from their experience of birth with grief, regret, injury, emotional ill health, loss, dismissal, physical trauma, disappointment, disrespectful care, to name just a few. It's time to listen and to act. The New South Wales Birth Trauma Inquiry has given a voice to so many. This is urgent. Anything less than respectful maternity care should not be tolerated, but I ask how? How can we keep up this pace of guidelines, policies, procedures, long lists of exclusion criteria, risk, over-servicing, over-scanning, mountains of paperwork? It is all very big and very scary for women. We are forgetting to listen to women, watch women, use our skills, respect each other, feel valued, and most of all, work collaboratively. So it's no surprise to me that I choose to support women and families in these ways, once again at home for home birth and in their matrescence. I am proud that home birth is now available for women in my community and that I am a part of it. I feel privileged to attend home birth as a second midwife and wish to raise the profile of my essential role in this arena. One, in supporting and collaborating with the endorsed privately practicing midwife to comply with the safety and quality guidelines for PPMs. And two, to be present for the birth of the baby, fulfill the important skills of obstetric emergency management, adult basic life support and newborn resuscitation, and provide midwifery care for the whole family for their intrapartum experience. Now and finally, as from the perspective as a matrescence coach, it has been 4 years now since I have been offering trauma-informed birth debriefing and working with women and families to own their experience of their perinatal journey. I am happy to report that it is contributing positively to women's experience, especially following birth trauma. What I truly want for women is to intercept the chance element of birth and for continuity of care and carer to prevail. When women get to choose where and with whom they birth, all risk choice, they are receiving gold standard maternity care. As a matrescence coach, I have heard firsthand the impact trauma has had on people's emotional health, relationships, connection with their baby, relationship with breastfeeding, and their sense of self and identity, to name a few. With government support, there is a huge opportunity to change the status quo and make real change in this maternal mental health and perinatal wellbeing space. If I was to dream big, it would be to afford all women and their families a free ticket to a birth debrief, and for this debrief to be with a trauma-informed, culturally sensitive facilitator with experience in perinatal emotional health and wellbeing, and who is independent from the service who provided the care, if requested by the woman, partner or family. This ticket has no expiry and has no criteria or restrictions. It is individual and is for everyone. Thank you. Thank you for listening.
Thank you again, Samantha, and your experience, sharing it with us. We really appreciate it. Our next speaker is Samantha Rasa. She's a mum of two who has birthed at a large tertiary metropolitan hospital through the GP shared care and at Wollongong Public Hospital through midwifery group practice. And she's got two young children and managing to spend her time sharing some time with us as well. So you there, Samantha?
Yes, can you hear me?
Yep.
Okay, perfect. So I'm here to share my two birth stories, which varied greatly due to the differing modalities of care that I received. My first birth occurred at a large tertiary metropolitan hospital. I attempted to get into the midwife group practice, however, due to limited spots, I was unsuccessful. I was then seen by different doctors from the obstetrics team throughout my pregnancy and only met one midwife during my pregnancy. I was unable to attain the continuity of care that is the gold standard. This left me scared for me and scared for my baby. In attempts to have some level of continuity of care, my husband and I reached out to private midwives. The cost was prohibitive, even when engaging them just for prenatal visits and not a home birth, as well as having no availability. In the end, we engaged a doula to support us because I felt that given I was forced into an obstetrics lead modality of care with no continuity, combined with the fact that it was COVID and there were no antenatal classes, it helped me be well informed and understand my body so I could have a natural birth and positive experience. Also, I wanted. From the outside, my birth was textbook. From a mental health perspective, it was traumatic. The night of my birth started at 10 p.m. We attended hospital after my waters broke and were advised to return in the morning around 8 a.m. It was clear as a first-time mum, the midwives expected my labour to progress at a slow rate. This was not the case, as intense contractions started around midnight. During pregnancy, I was told to contact the hospital when my contractions were 2 to 3 minutes apart and lasting for 1 to 2 minutes. This actually occurred within the first hour of labour and remained this way until I gave birth 7 hours later. We phoned the hospital twice, first at 1 a.m. and then again at 2 a.m. Each time we informed them I was experiencing intense contractions, but because I was able to speak to them on the phone, they insisted I was in early labour rather than active labour. They continued to recommend I stay at home, insisting I'd have a long labour. I felt dismissed, unheard, my needs not responded to. This only exacerbated stress and anxiety. I was tense and scared, and I started to have spiraling negative thoughts, and my self-talk was, I can't do this if it's going to be so long. The panic set in, and I knew this was not the right headspace to be birthing my child if I wanted a natural birth. We therefore called our doula as we were not receiving support from the hospital. She was able to calm my nerves slightly. However, she also supported the hospital's advice to stay at home. It got to the point 5.5 hours after contractions started, I had vomited and surges were 0 to 2 minutes apart, that I physically crawled to our front door and said I was going to the hospital. I remember getting to the hospital and keeping my eyes shut tight the whole time whilst being wheeled into the room to be checked, as I felt no one believed me and I didn't want to look at them. After several contractions in a row, the midwife was able to check my dilation and realized I was fully dilated. She stated, "Wow, you were fully dilated." This was around 6:20 a.m., 6.5 hours after I felt my first contraction. She then asked if I could walk to the room down the corridor, whereby I stated no beeping chance, and got back into the wheelchair and was taken to a birthing suite. When I got myself into the bath, I still wasn't heard. The midwife had no sense of urgency and walked away to complete paperwork. My husband had to state that he could see the baby's head. When she came back, she said, "Oh, it looks like you'll be pushing this baby out next contraction," to which I did, and Seamus was born. Afterwards, I felt so sad and depressed about the whole experience, which was devastating because I was so excited to give birth prior to my interactions with the hospital staff. I was treated as the rule rather than the exception for first-time labourers. If I didn't insist on going to the hospital, I would have accidentally free birthed at home, which would have been extremely risky and frightening. When I tried to talk through my birth with the midwives who visited afterwards, they still didn't hear me and kept saying, "You had a textbook birth," and dismissed me once again. Therefore, it took me a significant amount of time to come to terms with my birth, and a psychologist was required to support me work through the trauma I experienced. I'm still working on it. In summary, leading up to the birth, the support from the hospital left me feeling frustrated. The lack of being heard and seen as an individual rather than the majority during the birth was appalling, and the consequence was birth trauma. I obviously had reservations about going through this experience again. However, we started trying for another child 10 months later. We unfortunately had 4 early pregnancy losses in the next year. After having 1 round of IVF, we finally had a viable pregnancy. I had to have hormone therapy for 16 weeks, which meant a daily injection, pessaries, and an oral steroid. My mental health was fragile due to the losses, and I was diagnosed with perinatal depression. This time, however, I was fortunate enough to get into the midwife group practice, MGP, at Wollongong Hospital after advocating for myself. I was initially accepted, but then told I potentially had too many risk factors for the program and was unable to birth at home, which was my first choice. Being an occupational therapist who has supported children and their families for many years, I decided I would vouch for myself and get what I needed and deserved. Finally, I was able to get the continuity of care, the gold standard. My midwife is Vivian, who I now have so much respect and trust for. My second pregnancy was much more physically and emotionally challenging than my first, but I felt extremely supported throughout. I was heard, respected, and trusted. Seeing the same person at every appointment put me at ease and allowed me to open up about my fears. Vivian was able to provide extra care and support targeted to me and my needs, the individual. Even though I had additional mental and physical health struggles, I knew exactly what to do and where to go due to Vivian's expertise, such as psychology. MGP also provided an antenatal class where I was able to share my first birth experience and inform other parents of what can happen. Quinn was born after an induction, which I did not want. However, I wholeheartedly trusted Vivian. I knew it was what was needed at the time. This trust helped me feel safe. It helped my body relax and allowed me to connect to the experience of delivering my baby. I have no doubt this helped my contractions to start naturally shortly after Vivian broke my waters, and Quinn was born within an hour. Vivian was so supportive during my birth. She listened to me, made me feel heard and cared for, and guided me through the whole process. I came out of that birth so positive and could not thank her or MGP enough. It was such a beautiful ending to my story, and I'm so grateful to have been a part of MGP. To conclude, every single woman deserves to access continuity of care through their pregnancy, labour, and postnatally. Women create lives and deserve respect, support, and education. They deserve to be listened to. They deserve to be treated as an individual for their specific needs, not based on generalized rules that are meant to be one size fits all. All women should have continuity of maternity care with a known midwife of their choice. Thank you.
Thank you, Samantha, and thank you for sharing your experience. It's